Yes. Hi, Dr. Namrata. Thank you so much for having me. This is a very, very special topic because oops in ophthalmology, I think, has roots in everybody's surgical journey. And I think everybody is going to have some oops or something somewhere. I'm going to show you some of my oops, and I hope everybody can see my screen. I don't
Yes.
have any
Yeah,
financial
yeah,
interest.
yeah. We can
I
see.
don't have any financial interest in my topic today, but I will begin with something that I had coined the term VAP. VAP is vitrectomy assisted phacoemulsification, and this is a procedure done in aqueous misdirection, coloboma, wherever there is positive pressure coming from behind. Uh, and I'll tell you the technique is basically to do a little bit of dry vitrectomy to free up some space in the anterior chamber. That was the technique that was this thing. But here I'm showing you something that did not happen as per plan. So once I'm doing my rexus, I'm doing my hydrodissection over here. I have done my hydrodissection and I've started my phaco, but as soon as I am close to completion of my phacoemulsification, I noticed that this bag had the anterior capsule rim has actually ripped all the way to the periphery, but it's not gone behind. And once I'm doing my trocar to do my VAP, that is vitrectomy assisted phaco, this is my intermittent vitrectomy where I'm doing 1,000 cut rate and for about 4 5 seconds. I'm now doing my irrigation aspiration. Everything looks hunky dory. Everything looks good. I've got a good bag, except for this inferior little bit of a rip. If you watch here in this quadrant, I've got a rip, but it's not gone to the periphery. So I'm okay. And I'm continuing my procedure here, thinking that, you know what, I'm going to be able to put this lens in place. And things don't go as per plan sometimes. And the oops moment is right about now when I'm trying to dial this lens or drop this haptic in place. But then I suddenly realize, oh boy, something's not right. That rip, which was inferior, I've actually managed to push it so far beyond that now vitreous has started to prolapse into the anterior chamber and more into my wound. So now I have to think of what to do now, and I'm now thinking of my plan B. So I've taken off my iris hooks. I take the iris hook tire and place it into the haptic, so my IOL now does not drop down. Now what I do is basically make my partial thickness flaps, because now there's no sulcus. I need to make my secondary IOL implantation. So I'm making my partial thickness flap. I'm showing you a way of switching from plan A to plan B and yet getting great results in these cases. So basically doing a bimanual technique. I'm now externalizing the first leading haptic and externalizing my trailing haptic. Once both are externalized, I remove my iris hooks. And once these two are removed, I'm tucking my haptics into the Gebel Chariot's tunnel on both ends. And now my IOL is pretty well centered, but my pupil is not. So I'm trying to now renegotiate that pupil or reconstruct that pupil to make it more round, make it more robust, and block off all the rays that could affect an abrasion due to the light rays of that defect. And end of it, this is how it looks post-operatively first day post-op. I also wanted to show you another case, which is yeah, I still don't have any financial interest. I'm going to take you. So here's a case of another vitrectomy assisted phaco, but here's a very hard, dense nucleus and a larger coloboma. If you have a look at it, I would rather refrain from doing any trypan blue or blue rex in this case. But the idea is to basically use iris hooks, visualize your rexus, make sure that your rexus is large enough so that the nucleus can come out. Once your once your nucleus, once your rexus is large enough, I'm doing a vitrectomy assisted phaco again, and this time around, I'm now doing some hydrodissection. Remember, guys, this is a very hard nucleus. So I'm now trying to chop this nucleus somewhere in the back, but I know that this is not an ideal situation. And I started to see something I was not so happy about. This nucleus is trying to find its way in between that gap and trying to find its way down south, which was not very pleasant to watch, to be honest. So now I'm thinking, you know what, I'm going to remove my iris hooks. I'm going to place this nucleus into the anterior chamber and then try and emulsify it. Now, it's not a very pretty sight to watch, especially such a hard brunescent cataract, but it still didn't listen to me. The minute I pushed in the saline, it was trying to find its way down south. And it's not a pleasant sight in these scenarios. My plan B, to go to plan B, was to switch over to a small incision and actually do a glued intraocular lens in this case. But basically, all in all, this was not a pleasant scenario. But I did learn something out of this plan B. That how can I prevent from moving, a hard brunescent cataract? I could do an SICS in this case and get away with it, and that's okay. But could I do it in any other way where I retain the bag and keep that bag complex well enough? In this case, I couldn't because of the bag not being stable enough, thanks to my too much maneuvering in that scenario. But what I'm also showing here is basically how do you switch over from plan A to plan B. I'm going to show another case immediately post. I got this case about a month or so out, and it looked exactly the same. And that's why I wanted to shoot both these cases, and something that I learned in my previous scenario of how do you prevent this problem from happening. So the first thing I do is place my iris hooks, do my rexis, and I'll show you another trick which I think is important to understand. I did not make a large enough rexis. So whenever you do that, please take it with a pinch of salt, that you need to expand uh, that rexis. And so I am enlarging that rexis out larger. Now I'm placing capsular hook. Now this capsular hook does two things. One is it stabilizes the bag, and it also prevents my nucleus now from going into that space. That space, the coloboma space, it will prevent me from going into that direction, prevent this nucleus from moving in that direction. And that's something that I really learned and took home from that previous case. And now in any case where I have more than 4 clock hours, remember guys, 4 clock hours of coloboma, I will always place a capsular hook in place, so that prevents my issues from escalating. And now I'm placing, and another small trick over here is, don't you have to watch the end of that capsule tension ring going in, because if it doesn't, this is what will happen. You need to ensure that it goes in. You need to make sure that that rexis is round. Lots of small learning points in this video, which honestly I couldn't talk about, but I have tried to address all the small points which you really go on to make this a beautiful uh, learning video. And at the end of it, did remove all my cortical matter from here. And now I'm doing my single pass 4-throw pupilloplasty in this case, to close that pupil and make it round enough and ensure that this patient gets absolutely great visual results as well as iris defect closure. Probably in hindsight, I might have done another pupilloplasty to close that gaping wound in the inferior quadrant, but this was one of the first few cases way back in the day. Thank you very much. I don't have any financial interest in my talk. Thank you.